25 years, and this has not been just 25 years of journey. It is a wow journey which has become an idol for all the ophthalmologists practicing in the area. We look up to the standard of care which is being given at Drishti. We take them as idol and try to follow their protocols, and we wish them all the best for future also. And without wasting much of time, I will now ask to start the program so that we don't miss the lectures from my esteemed faculties. Thank you.
Thanks, Dr. Ashish. I'll now, without any ado, we'll start off with our first session, which is a 3D video theater, which we worked very hard to set up, and let's hope it works well, because it requires us somewhat of expertise. And in fact, today one of the lectures by Dr. Samaresh, I'm looking forward, who's been able to set this up in his hospital, and he'll teach us how to set it up in your own hospital without spending a bomb. And so we'll invite the chairs for the first session, Dr. Harsh Bahadur sir, and Dr. Vinod Arora, and Dr. Yusuf Rizvi. And the panelists for today morning session, Dr. Smita Mehra, Dr. Amit Singh, I think he's going to join a little late, Dr. Sushil Oja, and Dr. Neelam. So we'll start off, and the program starts with the first lecture by first surgical video by Dr. Meenal Patil, who is a pediatric ophthalmologist and strabismus surgeon at our hospital. And she does a fair bit of squints as well, so she can prepare her presentation. And of course, we have two super chairpersons. We have Dr. J.S. Tityal sir and Dr. Natarajan sir, whose expert comments will always be welcome throughout these sessions, because they are the ones who are maximum experience with 3D surgery in their respective fields. If anybody doesn't have the 3D glasses, you can ask our audiovisual team to provide you. Once anybody needs them, pick it up. Perfect.
Rameshwar? Like.
Double click. So, good morning everyone. Such a lovely morning today. I will be starting with the squint surgery. Besides, like all cataract and refractive doctors are used to various gadgets, and they use intraop OCT, and they have a lot of machines to help with them. But we as squint surgeon, we usually don't use so many gadgets. But because we have this calister with us, I could get the surgery done on the machine, and I'll share you my experience with it. So this is a recess resect procedure for exotropia. I will be presenting. Intraop FDT is must. After doing the peritomy, you hook the muscle and separate the muscle. Take the sutures, first partial thickness, then full thickness, and again the same full thickness. Same on the lower side of the muscle. Partial thickness, full thickness, 2 muscles. Cut the muscle. Mark at the point where you have to do the resection. Attach the suture to the sclera. So this is the point where we have a very good focus in the machine, and you get the scleral depth properly, and you will have the 3D effect with the machine, and there is very less chance of scleral perforation. You tie the muscle, and then use the fibrin glue to oppose the conjunctiva. This is the MR resection I am showing. Separate the muscle from the tenon. Take the sutures for partial thickness and then full thickness. Again, very less chance of scleral perforation because of the very good depth perception. Similarly on the other side, maintain the hemostasis with the mosquito forceps, and cut the muscle and suture it at the insertion. So one of the perk of this machine is intra-op OCT. So here you can see the muscle. You can see the insertion of the muscle. Here. You can see the insertion of the muscle here. Okay. So it's very useful when you are doing a surgery in already operated cases like re-surgery, especially when you don't know where the muscle was operated and you don't have any data. So definitely this machine gives us a wide surgical field. So instead of using loops or microscope, we can use this machine to have a very good view in the surgery. It has excellent depth perception, and yes, one of the perk is anterior segment OCT, which will help in finding the insertion, and most importantly, it will give us a very happy patient at the end, which is really matters. Thank you so much.
Because I've been told that it's challenging to actually do external suturing. Dr. Meenal is doing regularly sprints and she's happy about it. But I've heard from a few people that intraocular surgery becomes very good. But when you're doing some external suturing, it may be challenging. I thought I'll ask you if other people are using it.
There would be some learning curve for some of the important steps where you require more, stereopsis and depth perception, which gets a little modified with the 3D heads-up microscope. But once you get into that, nothing better than that device, because it is a very addictive device, and it's very difficult to get away from that. As far as Gaurav said correctly, as far as intraocular surgery concerned, we don't find any difficulties, because you are doing quite a controlled procedures. When you are doing suturing, your movements are little, more, you can say wider, and to have the perception and the angle which is required sometimes can be tough. As far as we are concerned, all people are doing surgery in all the devices, because we have multiples of these microscopes, 5 of them, and everybody does surgery in that. And we find the greatest advantage for us is in cornea surgeries. Because she rightly pointed out, the OCT is a major advantage of this device. Though we had earlier microscope which had OCT, but that OCT is not of a great quality. So surgeon does have a view of OCT, but it's very small one and sometimes not visible. Sometimes I have to put off my microscope light to see the OCT very clearly. With this screen, you can see the OCT beautifully in front of you, and you can do anything from your side only. Assistant help is also less required for OCT management. Squint surgery, or people also doing squint surgery, and they find it is very comfortable. As far as I'm concerned, because I do every surgery from temporal side, and I've learned my keratoplasty from superior side. Now to shift the suturing from the temporal side sometimes difficult, because my 3 and 9 axis are changed to 12 and 6, and that is a little challenge sometimes to have that hand manipulation. It takes 1 or 2 cases to get rid of that little difficulty. So squint I don't think will be difficult, but some keratoplasty surgeons do find difficulty in adjusting the hand orientation to begin with in these cases. Otherwise, once used to this, nothing better than that. I think we'll come to subsequent advantages which you'll see in other surgeries also. And people use for all types of surgery nowadays. Even orbit surgery, people find it very comfortable now. You can go to the depth, you can do a high magnification, see every point can be seen very beautifully.
Thank you so much, sir, and thank you, Dr. Meenal, for that nice touch. I'll now invite the next speaker so I think it's the next one. Can you play the next video? Actually, it was a glaucoma surgery which was to be shown by Dr. Amardeep. Unfortunately, somebody passed away in our family, but she sent us she's our glaucoma consultant and she's made a recording. Can you play that from there, or we'll play it from here?
was placed with a squirrel trap and the rectangle was carefully secured using metal shears, then sealed lightly. This is projected to siphon the form and check the occupancy of the plate.
With that, I'll invite our next presenter, Dr. Vijka Patnaik, who's cornea consultant at Drishti, to please show her video.
Just I'll take 1 minute. You have seen these videos. So आपको क्या लगता है कि क्या advantage है system का? Anybody? Depth perception. Anything? Ergonomics, yeah. और कुछ? Low light. आप लोग देख रहे हो कि आपको जो लग रहा है ना कि it's like you're doing something in a depth. But actually जो surgery होती है, you don't realize this. You get used to the system. There's no artificial depth creation for surgeon. Because people feel they'll be artificially using much deeper and you might create complication. That is not true. Like especially Artimo, you don't have that concept. In Unity, people did have a difficulty because there was a lag. That is a major concern when we started with these microscope 2016-17 in Unity. There was a definite lag between the your frame and your timing. With this JICE system, the time lag has decreased so much you don't realize. It's like a normal surgery. Only thing, as Dr. Vinod said, your position changes your advantage. You are sitting straight most of the time. Only thing, you are a little tilted because the screen is here and your optics are here. A little tilt will be there, but your body will be straight. And that's a major benefit for a younger people sitting here because they'll be doing surgery for next 30, 40 years. We already had, all the spinal things are still, they're in a bad shape. But even now also it is advantageous. Yes. Yeah. That the stain in your neck has gone totally. That's the major advantage I feel. Second is the magnification. You can go to highest magnification and no distortion, which is a major advantage. And it is true for a cornea surgery, true for retina surgery where you require a high magnification. In microscope, if you increase the magnification, your distortion increases. You can't see things clearly. That's a major advantage screen you have here. And third, he said rightly, was we can operate with very low light, and patients under topical, they become very, very comfortable. But image is as sharp as you can see with the microscope also. So surgeon has the same view, but patient has a very low light. Great advantage. Apart from the other advantage of teaching other things, people can see all those things. But what we are seeing now with this polarized glasses, actually the view for surgery is not like that. It's like a same like a microscopic view. So you should not be worried that you'll be working in an artificial area. It is a normal looking area. So people should have in future more microscope like this. We should have these things because your view is going to be much better. Much better. Especially for older people where you require more brighter images and more large images to see clearly. For young, very, very big screen, yeah. Okay.
A very good morning to everyone and a warm welcome. I'll be presenting a case of intraoperative OCT guided LASIK flap wash for epithelial ingrowth, and there is a very nice review article which is actually co-authored by Professor Tityal sir. I'm sure, my video, because experience with this machine is very limited and I'm still exploring it, there are going to be a lot of shortcomings, so at the end of it I think sir can guide us much better. So this is the case of a 31-year-old male who presented with progressive diminution of vision in left eye since 3 months following injury with a plastic toy. And he had history of undergoing femtolasic surgery. In 2012, he was operated elsewhere. At presentation, his uncorrected visual acuity in the right eye was 6.6 and in the left eye it was 6.12. And this is what his autograph looked like. His left eye showed significant induced irregular astigmatism. So on slit lamp examination, the left eye showed an island of epithelial ingrowth, nasally extending from around 8 to 9 clock hours. And you can see the epithelial cell nest very nicely. And there was another island at around 5 to 6 o'clock inferiorly. So this is what his pentacam looked like. There was an island of central and peripheral steepening which was induced by the epithelial ingrowth, and the OCT nicely shows the hyperreflective deposits. So based on this, we decided to go ahead with a flap wash for this patient. Can we have the video in 3D, please? So you can nicely see the hyperreflective deposits in the. It's not in 3D. इसका नहीं तो जो separate है। Sorry about that. So you can see the intraoperative OCT shows the hyperreflective deposits and the area of the epithelial ingrowth. So in this patient, we had taken up a bit dilated to have the fundal glow, but with the IOCT, I think that won't be required anymore. So the epithelium overlying the area of epithelial ingrowth is scraped off, extending beyond the flap edge. And the IOCT actually helps you to nicely see the extent of the epithelial ingrowth and also to basically have a limited flap lift also depending on the extent of epithelial ingrowth. Although in this case I did a complete flap lift, but you can avoid that. And it also highlights the edges nicely. So after the dimple down maneuver, you can just avoid the unnecessary manipulations and enter the right plane and avoid excessive manipulations. So once the flap is carefully separated all around and lifted up, the islands of epithelial ingrowth are scraped off from the stromal bed and also the underside of the flap. And basically the IOCT can help you to make sure that you remove it completely and there are no residues or leftover islands of epithelium. So you can see the underside of the flap is also nicely scraped off. of limited exposure to the machine. I mean, I've not really used it to its full potential and focus on the area that needs to be. But yes, you can focus on the flap at this point and then make sure that the epithelium is completely removed. Once that is done, the flap is then reposited and repositioned and smoothened out and completely dried out, and then you have to wait by the clock for at least 2 minutes to make sure that the flap is completely and nicely well opposed. And you can see in the OCT that the flap edges are now nicely opposed, and also the hyperreflectivity has significantly reduced, although because of some amount of fibrosis you can see a faint hyperreflective line, but I think the deposits were like completely removed, and then the BCL is placed at the end of the procedure. So now you can shift to the 2D, please. So this is the image of the patient post-op 1 week. The visual acuity was restored to 6 parts, and you can see the interface is pretty much clear with minimal fibrosis, and this is what his OCT looked like. Thank you.
Very nicely managed. I think the concept is there, use of OCT for all procedures, and this is helpful in this particular condition also. Not only for epithelial growth, it is helpful for the macro folds management also, because you can see the entire folds getting off also. And you rightly pointed out to see the surface, because ideally the both surface, the stromal surface and the flap inner surface would be clean, and you can appreciate very nicely with the IOCT also. And especially in epithelial ingrowth, which are little paracentral, or which are located to the inferior side, like you may not have to lift the entire flap. Like you can lift the half flap also, and you can easily take off the those epithelial nest and put the flap back. In that way, don't induce the further damage to the other area of flap. And sometimes the recurrence of epithelial ingrowth is there. So it's always better to lift only that area which is of concern, and that can be easily achieved with the IOCT. We can see better. And that is alcohol or vitamin C to the transient recurrence happening. One important area which we have realized, in the chronic cases, long-standing flap damage, sometimes you do have a tract formation in these cases, and that is beautifully seen in the OCT picture. So sometimes the microscopy would realize some sort of defect in one area. And OCT picture will show that one area you have a non-attachment. So that can be tracked. You may have to put a suture at that area to flatten that track. OCT is a real boon in that case. Very nice.
Thank you, sir.
That we are going to change track, and we have now next none other than the most renowned retina surgeon of the country, who's been setting, I mean, he's supposed to be outstanding as a VR surgeon, and people say that he does magic when he does retina surgery. So I'll invite Dr. S. Natarajan, who's come all the way from Bombay, to please go ahead and show us his experience with the RTO 3D system. Thank you, sir.
Thank you, Gaurav, for the opportunity. And this is, I think, all of you seen the basics given description by Gaurav. Yeah, I can see that. I think this is a combined surgery where Dr. Kavita Rao and Dr. Anupam Deshpande, they do the cataract. Usually I ask them to do in the beginning, and then I think you have seen enough of cataract, I think. actually, I think I only do all the procedures under 3D, and I don't know, sometimes our anti-segment surgeons are not still using it regularly, but I use for scleral buckling or anything. I don't do anything, even injections I like to, I was telling Dr. Tetial that I like to use the thing and record it also for the, even giving intravitreal injection. I think the reason is, it's like almost, like now you're playing, it's like playing a video game by the children, and I think one is people in our age group, we can prevent Alzheimer using the 3D, and so this is what I make the anti-segment surgeons do. They do the cataract, put the lens, and then we go ahead and do the 25 gauge the 3D, and here I'm doing the 3D vitrectomy, and so actually it is like seeing a big screen, and you see magnification wise, I think that's what I enjoy. Even you go to the periphery or going to the center and under air, the visualization is amazing, and if you magnify in a regular microscope, many times the edges are blurred, but here you see the full screen, the same, and as you see the screen is yesterday when me and Dr. Tetial were there to see physically the OT, and I think the system is expensive because of the screen, and I think the Sony is having the exclusivity for doing here. Here you can see I have done the fluid air exchange. Under air I do a peripheral vitreous basic excision. Sometimes in young individuals PVD is not done, so I make sure that under the air I can do the suction so that you can see some amount of vitreous which is attached, and I'm present using the brilliant blue to stain under air. I like to do under air. So I think I mean, whatever surgeon you are, I think 3D, the advantage is that you see the center and the periphery in the equal precision, which is what is important for a ophthalmic surgeon. So actually, I am collecting some 4 articles on how to be a good eye surgeon, and I'm actually giving a talk to the postgraduates on Tuesday. I think the main thing is 3D will really help you to enhance your skills. So for that, I think first you have to be a regular. I'm using the flexi loop to create the to make a nick in the ILM, to do the macular axis, which is I think a wrong term compared to the capsular axis, and many times we keep. So you can see this particular ILM is quite firmly attached, and I'm removing it. So you can either use the same flap if you want to make a flap. So here I'm removing the ILM. There are some like a pedicle hemorrhage is happening, indicating that and this is actually a pit. So I'm actually removing the ILM and closing the hole, not the pit with the ILM. So there are some dot hemorrhages, which is I think not a problem. So you have to be careful when you're doing the fluid air exchange, particularly using the and the surgery is over with the air and here I'm using the amniotic membrane to make close the pit. So this is the best part of ophthalmology. We can borrow technology from both anter-segment to the posterior segment, and one of them is that AC maintainer, which I like a lot for doing even in a fakie guy. Thanks to my friend Dr. Cesare Forlini taught that you can infuse the eye even through the AC. So you can see when you are removing some part of the vitreous near the optic disc under air, you can see the amniotic membrane is jumping, so you can even trim it later. So here I am now putting it on the optic pit. So then you leave the eye and put the patient on prone position so that the pit is. So most of the time I think I introduced. Can I have the next slide? Is this the second slide or? Oh, how do I go to the next slide? 360-degree peritomy using the 3D. So I love doing the peritomy. The reason is if you do the peritomy properly, it looks like a simple procedure, but for a scleral buckling surgery, the peritomy is very important. The reason is if you don't close the conjunctiva and the tenons properly, you will have the suture exposure. And I also don't use sutures, so I have the inferior rectus now being tagged using the white suture, the bridal suture, and the horizontal muscle I use the black suture. The reason is one black and white, one white is the fellow can catch and turn the eye. We need to turn the eye properly so that we can expose the sclera properly, check the vortex and also the integrity of the sclera, because sometimes in high myopes you will have a thin sclera. You have to be careful, you can have perforation. So here I am using the hockey stick knife and making a loop, a scleral loop, where I pass the 240 band, which I do it in the 3 quadrants. Usually a single break or a lattice with a hole in one break. I use the that quadrant I leave. So now this is done in all the 4 quadrants. It takes a few minutes only. I think the speed is not important and time is not important, but obviously some people do for longer, and I do. By the time you finish cataract, I can do a buckle, but I think everything is in the mind. So I always request, and all the postgraduate, I'm telling request because I put it in the manual for the fellows. And this is a Watsky sleeve. So you see no sutures used for when you want to do a 240 band, all the 4 quadrants, and the Watsky sleeve, which also is made of the silicone. So you can even tighten and then go ahead with the vitrectomy with a buckle. So where now I have tightened the 240 band, which I can release later. So I made the 3 ports, and you can see there's a total retinal detachment. Macula is on, and you can see the buckle is tighter now, and that's why it looks very prominent. And I will loosen the buckle after the completing the vitrectomy. So this is just to, you can see the macula is still on. So I'm using the PFCL, squeezing out the subretinal fluid through the peripheral retinal break. And there are some small bubbles which you can make it into single. So now I'm trying to identify the break. There's an optical phenomenon, I don't know whether you could see, I'm not able to see from here, where through the break, the subretinal fluid comes into the vitreous cavity, and it looks like an oil mixing into the water. So that's how that's called the, that's the horseshoe tear which you saw, where the subretinal fluid has come through it, retina is totally attached. So these sort of patients can get 6.5 and 5 after a vitrectomy buckle, even in a phakic eye. So that's what I love to do. So I compete with the intraocular lens surgeons for long. When I started the hospital in 90, Dr. Badrinath and Dr. J.N. Rao inaugurated, and they told me, Dr. J.N. Rao told that you people carry the visual acuity chart in the hand, in the pocket, because you're only counting fingers vision you'll have. Now I think we compete. We can get 6.5 and 5 with any complicated vitreoretinal surgery, and you can see the retinal endolaser being done around the break. And after completing, I will loosen the buckle so that you need a moderate buckle so that you don't induce myopia. And already a myopic eye, don't induce a high myopia. So make sure that the entire base is excised around in the vitreous. Under the air, I completed. And now you can see I'm removing the ports, and I know I don't have to suture. And I remember Professor Peter Kraut from Marburg, Philipps University came. He wanted to check. And he asked me how many times you suture a 23 or a 25 gauge after a vitreoretinal surgery. I said no, most of the time, 99.99% I don't suture because it doesn't leak. And every time the pressure is high the next day, so that indicates your entry, beveled entry is beautiful. So the whole thing is I want my talk also after some time will be on 3D fantasy surgery. It's really a fantasy for ophthalmology. Unfortunately, the expense is not commensurating to the enjoyment you're having. But I think I feel like I'm sitting on the optic nerve and operating on the retina. That's how I keep imagining. And this you can see there is no suture. So it's a sutureless vitreoretinal surgery. A buckle done, and then you can put the glue and then close the conjunctiva. Make sure that it's done well. And subconjunctival antibiotic because we are using a silastic material. Thank you very much. I'll be happy to answer any question. So whether you are an anti-segment surgeon or can I have lights on? A posterior segment surgeon. My suggestion is read the chapter called Surgical Self-Education in Microvitreous Surgery by Steve Charles, and in my book Cutting Vitreous Surgery again by Springer. The reason is you have to have a game plan like playing soccer the night before. So we make retinal drawing, we make a plan, and on the table there may be change because and that's how you play soccer. You play with your team, you have your own coach, and the opposite is here retina and vitreous, and they will play their game. So I think finally you play a game to enjoy it, and winning or losing is not the but here somebody's eye, you have to win. So I think I also will end my talk by telling, read the book by Richard Green called Concise Mastery. You have to be a master in whatever you are doing. So you do the procedure again and again, you will be a master. And that's what Malcolm Gladwell has said. If you spend 10,000 hours, you can play music like Beethoven. So the same thing, I think I have done more than, I don't know how many, 20,000 or 30,000 hours in the vitreous cavity. Thank you.
Thank you, sir, for very nice videos. And I totally agree with what you said, and thanks for showing the buckle and the art of the buckle, which is kind of going away, especially for the benefit of the PGs and the fellows who are here. And so, I mean, if you used Ingenuity, there's no financial interest.
Yes.
You would have seen the difference between the new Artivo system, because there used to be a lag
Yes.
in the Ingenuity, because I took a demo of the Ingenuity. And
I
we had-
used.
Yes. So that's why I'm asking you this question. So do you feel that with the Artivo, that lag has been taken care of, and you feel more comfortable?
I think it's again in your brain. So even in, I think it's like you have to be a master of the technology and should not be a slave. Even in the Ingenuity, I mastered it. I never had that. I remember the fellow came to train me and said, do this, do that. I said, no, yeah. For me, my legs and hands speak to the machine. And I think I don't need a training. But anyhow, that fellow insisted you should. I didn't do. I just sat and started the surgery. Same thing I do for any machine anywhere in the world. I don't know the language of the OT staff, but everything comes. I mean, in Mexico, I didn't have to talk at all. Everything was there, and that's the advantage of the modern vitreoretinal surgery with the biome, with the 3D. And I think the lag, probably you can master it, whether you're using Ingenuity or Artivo. And Artivo definitely has even that has an Artivo. It's half the time, I think.
Yes. And another thing I wanted to ask, that you showed very nicely in the two videos how they were, kind of different, was that in one you showed little grosser movements because it was outside the eye, and then the RD. And in one you showed, movement of the ILM and all that, which is finer one. So
Yes.
I noticed that in the Ingenuity we would have a little bit of an issue when you were going close to the retina. But
Okay.
with Artivo I feel that, I'm very comfortable even peeling the ILM.
Exactly.
So I think that, the technology has improved. I would
I
say.
explained that like having 2 layers of cloth, that much thick, you can see the difference in the 3D compared to the microscope.
And one last comment was that I find that with the Artivo, I'm able to see more in the periphery. I get a wider view.
Yes.
And in fact, sometimes what I have to do is I have to reduce the mag so that my fellows can see what I'm doing in the periphery. Because what happens is that I can see, but sometimes it's not displaying on the screen.
Right.
So I have to go down on the mag so that they can see whatever I'm doing in the periphery. So it gives a very wide view, wider than what you would have through the microscope oculars.
So we really enjoy the. I don't know whether you have seen the difference between the regular television, OLED and QLED. QLED is quality LED, and OLED is organic. And this is something like that, the medical grade Sony system, which is beautiful. You don't have a strain, and you have almost eyes focus for distance. So the OLED is similar. You can watch anywhere. I lie down and watch, which is supposed to be in the Parsons book, a bad visual hygiene. But I think in this, it's really great. Anywhere in the hall, the person can see. But I want some postgraduate to ask some question. If they don't ask Gaurav, I'm not going to go.
I think Dr. Dityal sir has some questions.
Oh yes.
I appreciate, the advantage and the, changes which happen in the vitreoretina. When we started the postgraduate, you're right, like we say, okay, we have done the surgery, rest, it's the God, if you can see or not. But you nicely pointed out that things have improved so much.
Yes.
One, I think, concern, is, which people do have is, after we settle down the retina, especially now, grossly detached and with a lot of PVR changes happen. Sometimes even you settle down, you do have a little bit of, metamorphosia or other things attached to this. How to tackle those cases if patient comes with those symptoms?
No, actually, if it is metamorphosia, if you see some fine wrinkling, you can do an ILM peeling for those patients. So that's why even in diabetic macular edema,
You do a
ILM peeling.
I think that has changed the entire
Yes,
thing,
removing ILM has really changed the whole thing.
I think what Saurabh was pointed out, I also had the same feeling. Ingenuity did have a little lag. As an anterior segment, I was not very keen to use 3D system at that time.
Right.
And in our center, Atul was using all vitreoretinal surgery, but I said I'll not use for a cataract surgery. I wanted, Zeiss Altivogue for an anterior segment surgery. In fact, I acquired the, Zeiss for anterior segments.
Right.
Now our posterior segment surgeons are attached to that only. They have shifted ingenuity to one side now.
Okay.
So that is what Saurabh is saying, the change which has happened to, vitreoretinal surgery also.
Yes, definitely. And I think when Dr. Klasekar, he was there, I think in the meeting, he introduced this head-up surgery and everybody was asking, how is it going to be popular? He introduced first. And I'm happy that he is all the time first, and I'm also happy to be a part of this. So any questions from the postgraduate? Yes. Yes.
So what was the reason for that?
No, the reason is the patient, I think, if I remember history, the fellow also, he had a pit and the vision was not good. So that's the reason I said, I don't want to do another surgery to, again, do a redo surgery. So I did a ILM plug and the amniotic graft. So the patient vision is improved and he's happy. Yes. Abhi? Copy this one. 3D was there, yeah. ये वाला. This one. Same. Correct, same. No. He's just copying. Please.
All these systems, OCT or Unity, they were meant for a vitreoretinal surgery only because they wanted more magnification without distortion. And now I feel that anterior segment surgeons have more advantage using these systems. We have translated to all surgeries. They should go through, I think, I think I would have been a major beneficiary of OCT system in the microscope in the last 4-5 years. The entire literature on the OCT, microscope attached OCT, belongs to RP Center. In fact, read all the articles. They are path breaking for people to go through that, and I believe that this will be changing for concept for many things for many people. We are translated to all cornea surgeries. Like all surgery can be totally remodeled as your visualization changes. It is very useful for cataract surgery, especially the difficult scenarios, and it is useful for refractive surgery. We have translated that to not only phakic IOL, they translate to smile surgery also. Now the new attachments, the AMO people coming with the OCT attached microscope with their smile techniques. So things are rapidly translating to a different zone. And understand OCT will modify further. It will have a lot of artificial intelligence attached to that. As soon as the pixel comes, they tell you what is going to happen or what is going to be done. So it is the future for AI. Because AI will be based based on whatever thing we see, we input. And OCT going to change everything.
I think so. No, I think when I introduced the first OCT in 2000, Valnath was there. "Hey, why are you wasting money on this? What are you going to do?" I said, "No, Carbon Full Chat has done a wonderful job, and we should." I said, "See, I like to introduce everything first, and now I think every anti-segment surgeon has a OCT, so that they set the patient, they can decide, and they can anything which is not improving, they do a OCT. So I think technology, when it comes, probably people are not taking it. I always tell this, it's like tasting spicy food. So the problem is people don't know how to use it. No? So that's where I think that anti-segment surgeons are not able to use it. Maybe Gaurav and Titial will change the scene. Yes.
Good morning. Yeah, so after the nice videos by Natarajan sir, I'll just, for the benefit of the PGs and the fellows, I just want to show you the setup that we have. We have the Artivo for 6 months now. And you can see that, the fellow and myself, we are wearing these 3D glasses and no financial interest, but I'm working on the constellation. And you can see that it's ergonomically very nice on the neck, because you don't really have to, just a little bit angle to your gaze. And I'm directly looking at the screen without looking through the oculars. Can I have my 3D video, please? So the advantage with Artivo I found was that whenever you want to switch to the oculars, you can do so. The oculars are not taken off, as opposed to the Ingenuity, where it's cumbersome to switch between the screen view and the oculars view. In Artivo, you can do it seamlessly. It's very, very easy. So whenever you feel that you're not comfortable, operating through the screen, you can just go onto the oculars. So I'll just show you a video of a macular surgery. I hope it projects in 3D. Yeah. So this was a case of a large old macular hole, and after staining with BBG, what Dr. Natarajan showed, I also do under air, and now it's a large hole. I put the flaps in, but somehow, and I'm trimming the flaps because they were long, with the cutter at 0 suction. And with the cutter only, I try to just kind of put the flaps within the hole, but it's not really working, as you'll see in the intraposity, which is another very useful thing which I find with the Zeiss system. And you can see here, I'll just show you in a bit, that the flaps are coming out. You'll see, so they're long flaps. I've trimmed them, but still they have a tendency to unfurl and come out of the hole. So see there, I'm using the MIOCT and the flaps are out. You can see it, but you can confirm it on the MIOCT. So I'm trying to put viscoelastic this time, because sometimes viscoelastic works. People have used viscoelastic. So, but again, I'll confirm with MIOCT, and still the flaps are not yet in, and they are not staying in. So now the next thing to do is what you'll see in a bit. It's a very useful technique. So I'm injecting a PFCL bubble over the hole and over the flaps, and it should be big enough to cover the entire area. And with the finesse loop, I'm just gently stroking the peeled ILM flaps so that they are just moved into place, and under PFCL they stay put. They are not going to come out. So this is a little bit of a gentle maneuver. You have to be careful not to touch the RP. It's a large hole, and it's critical to have the flaps inside. For a smaller hole you can get away, but for a large old hole you have to make sure that it stays in. And now I'm confirming this on MIOCT, that the flaps are remaining inside the hole. And once I've confirmed that, and then I just go ahead and do a air fluid exchange, and then in the end I remove the PFCL bubble. And I did do an MIOCT at the end also, to make sure that the flaps were inside and the hole was nicely, sealed. and patient is doing well. He's about 1 week post-op, and even through the gas, I've been able to image, and the hole is closed. So that was the surgery that I had to show. Thank you.
Wonderful surgery, Gaurav. I think
Thank you, sir.
PFCL using is a great, like a third hand, which is they used to press in. And I'm happy again, Dr. Stanley Chang introduced that, and I brought it to India in 91 only. I think great. I think PFCL is really, the thing is you should not leave any droplets behind.
Yes. So for the benefit of the PGs, you have to inject within the PFCL bubble so that you don't get fish eggs, and so I found that with Artivo I could do this, and there was not much of a learning curve, to these procedures. And finesse, I'm a big fan of the finesse now, and I feel that it's a very atraumatic kind of instrument. We used to have the Thanos diamond dusted, which we have all used, but because of the shorter length, it used to be a little bit traumatic if you were not at the right, so this is more forgiving, and finesse is a beautiful instrument. I use it all the time to create an edge, to move things around, so yeah.
That's great. And there's a new forceps come from, it's called the shark
Skin. Yes.
Very nice. I think really, if even without a finesse slip, I could remove the ILM.
So it's like an ILM feeling forceps and a finesse built into one.
That's right.
Yes.
Correct. Exactly.
Thank you, sir.
How are you, Vinod? Good.
So our next video is by Dr. Shutanjay Das, who is also VR surgeon at Drishti, and he's one of the very fast, prolific surgeons. So let's see what he's going to show.
So good morning, everyone. I'm just going to show some videos of anterior segment complications. So this is a case which presented to us with a decompensated cornea following a complicated cataract surgery. So this was the initial picture of the cornea. Patient presented with a decompensated cornea, and on this scan we could pick up a so fundus visibility was not there, but on ultrasound we could pick up a dropped IOL which can be shown by the hyperreflective echoes. So initially the patient was taken up for a penetrating keratoplasty, which was done by Dr. Drishtikon, and we stabilized the graft, and after 3 months recently we operated for the IOL removal. So initially we made a scleral tunnel, a large tunnel, and a little bit care was taken not to injure the graft, those junction and other sutures. Droppers were introduced. We took up the case after 3 months from the initial graft surgery. PVD was still not there. We can see the dangling IOL.
one haptic was still attached to the anterior vitreous base, and a relatively mobile other haptic. The vitreous was gradually released from the haptics after induction of the PVD. One end of the IOL was released, but still the superior one was still stuck somewhere in the anterior aspect. With the help of a light pipe and a cutter, it was tried to release and allowed to fall on the retina. So once it fall on the retina, it was released from all the vitreous attachment, then the further vitrectomy was done. Then the AC entry was made. IOL was lifted up with a extrusion needle with active suction. And these things are happening under the biome, and now we are shifting to the anterior segment. The other end of the IOL was grasped with a forceps. Visco was of course injected to protect the graft. While handling it out, the haptic got broken, the haptic came out, and again we just kept on grasping with the other hand. We're just trying to take it out. And finally, the IOL was taken out. We recently operated this case. It was subsequently followed by endo-laser application, all 360 degree. Periphery was checked, and a fluid gas exchange was done, and case was closed. In the post-op period, initial post-op period, some sutures were broken, and we just took it out. This is another case. It was a vitrectomized eye for combined retinal detachment bilateral. The right eye's silicone oil was injected, and again the silicone oil was removed, but patient developed cataract, but unfortunately, because of the cutter touch of the posterior capsule, there was a nucleus drop. Since it's a vitrectomized eye, we straightway went with a bigger section in the active port because we have to insert the phaco-frag. A larger section was done, and a directly phaco-frag was used to take out the nucleus. And the wound was closed with a acrylic suture. Thank you. Thank you, Vaibhav, for making the slides, editing the videos. Thank you.
Excellent. I think
Thank you, sir.
you also mastered the fragmentum in the phaco-fragmentum in the vitreous cavity, which is very important because complications can happen because of the when you activate the fragmentum.
Sir.
So I think you've done suction and then bringing it to the mid-vitreous cavity to save the retina.
Thank you, sir.
Thank you, Dr. Das. And now I'll invite our next speaker, Professor J.S. Tityal sir himself. 3D theatre, sir.
Magnification is 6.9 times. You can see here, 6.9 and 5% light. So this 6.9 is actual magnification, which is a microscope magnification. As for my magnification, their concern will be around 8 or 9%. I operate around 8.8 to 9% in the magnification on the screen. So this is the advantage of this, where you can see the same picture as you saw in a 36%, 40% light, which is a normal user light we use. Here I could operate a 5% light for this particular patient. And have the next video. So I'm going to show you a few steps of our DMEC procedure. So this is a preparation of, we prepare light for this for phosphor chemical. I'll just fast forward it a little bit. This is the Teflon block, which is a little broader than a routine Teflon blocks. This is the tissue, which is upside down, because I want to mark it on the center here. So this is a corner skull button you can see here. So I'll put some marks so it gives you an advantage of centration. You can see I put marks here, then I'll reverse this to punch it. Once you reverse it, now I have the axis for center and periphery also, because I'm going to put two marks here. This is, again I'm putting back here. So this is a 9.5 millimeter mark for periphery. So this gives a, we don't put a through and through cut, we just make a light impression. And now I'll put a trypan blue dye to make it more visible, so that edges are visible here. So once I put a dye here, you can see I'm putting from periphery directly, I'm not putting the center, so that I don't damage the endothelium with the fluid pressure. And once it is soaked, you'll see the peripheral mark here. So this is a definition mark clearly seen here. So first is to make this attachment clear by reverse Sinski hook or Sinski hook. Then I'll take out the peripheral part of strip of endothelial complex here. Go a little fast forward here. So this is what I'm doing. Just releasing the adhesion in the periphery, so that when you peel it off, it becomes easier. For a PGs, normally for a DMEC, we take the tissue of a donor which is around 45 to 60 years, because the peeling is easier in that age group. Younger donors, difficult to peel. And you know that Dr. Aman Agarwal has the procedure called PTEC, and there it can be done for younger donors also. So once I have this peripheral area cleared up, I'll just peel it off with a McPherson's faucet. So this is very, very important. This peripheral peeling is of a non-required tissue. You can see. And this is now adhesion free. I'll just peel it off with the McPherson's forceps. So once I have the edge available, that can lift it up. And a little bit of fluids will be there on the surface, which keeps the endothelium wet, and it's very easy to peel it off. Now I'm making the edge visible with the McPherson. Normally you should have a McPherson which is not very sharp, has a slightly broader area of holding the tissue. I have an instrument which is modified McPherson, which is a little hub type of thing, which gives you an assessment of picking up. Now once I pick it up, I can just lift it up and keep peeling and go a little peripheral, because I had an attachment here. Yeah? Then I'm slowly lifting up. Now this step has to be very, very slow, so that you can pick up the tear which is not going regularly. So this is a half peel I've already achieved. You can see here very clearly. Here a little bit of attachment, I'm going to periphery, then tear it from periphery only. So once I have a 2/3 peeling, then I can go to other side. So this is what it looks like. I have a peeling now. I'll flatten it. Make a little opening in the stromal side. The endothelium is here. This is the stromal bed. This is the window which is open, so that we can put a mark onto the descemet side subsequently. So once I take out this, I'll go to the later stage. I'll get the flap back. I'll shift to the other area now. Can I have the next one? इसको बंद कैसे करेंगे? So this is the window you have now from the other side. So I'll put a S mark here. S is, you can see if it is clearly placed. I'll put this is the S mark instrument. And put a S mark onto the side here. So you have to gently press onto that. So this area is missing. I'll re-put it again so the S is complete. So this gives the opportunity when inside the eye you can see very clearly now. Now you can reverse it, put the cap back. So once you put the back, then you can punch it down. The punch will be around 7.5 to 8 millimeter. That depends on how much is the white to white of a donor host cornea. Around 1.5 should be detected, around 3 millimeter from that. If it has a 12 millimeter, you can go up to 8.5 also. Larger the donor, better is the chance of getting good amount of endothelial cells. So this is, I'm doing a 7.5 millimeter punch because this patient was around 11.5 white to white here. After punch, I'll put a blue dye again so that it's clearly seen and remove the undesired tissue again. Because remember, I had taken 9.5 earlier, this is the 7.5, so I'll have 1.5 millimeter undesired endothelium subsequently that will be peeled off. You can see I'm taking off that area. And subsequently, I'll take the donor tissue and make a roll of that. So this is how we prepare the tissue here. So this is a roll which is clearly seen. Let me see. Now you can S mark also, and roll is completely there. So this can be injected into the host cornea. We have next.
Wear it like this, it immediately sometimes becomes better. Just try. I just, Samresh and we were trying to figure out why.
That's the next trick. This is the donor patient. I'll go a little faster here. So this is what I'll put a different. This is the scoring which I'll be doing with the reverse Sinskey hook. We're going to score the descemet's endothelial complex around 8 millimeter here because donor was 7.5 millimeter and host should be larger than a donor roll as such. You can see the descemet is being peeled off very, very effectively in this case. The advantage here is, it should be very lightly, gently. You can see I am peeling off and I'm doing under the viscoelastic cover. So this is the helon inside the eye. So the helon gives a very nice regulated chamber depth and entire descemet complex has come out. You can do under air, you can do under VSS also. But for a DSEC, because the scoring has to be effective, larger than the roll, and scarring should not be there. Therefore, the reverse Sinskey should be very smooth. It should not be sharp. You can see entire thing I have taken out. Now subsequently I remove the viscoelastic, pilocarbonated the pupil and do an inferior PI, which is as vitreoretina people do it. We also do in a similar manner. I'll go a little fast forward here. So remove the viscoelastic. Parlor carbonized, I use the cutter here to make a PI inferiorly, which is small PI is done. Now I'm taking the tissue onto the my this injector, which is a glass pipette. You can see it is inside the glass pipette now. Then I'll inject inside the eye. So this becomes like a IOL injection. We had earlier modified IOL injector system for this. Now we acquired. Now the entire roll is inside the eye. Now the more importantly, this is the step which is very, very important, and you know that I'll be flattening the antechamber. A little bit of manipulation which will open the graft. You can see now actually it has to roll perfectly, and in IOCT also you can see what type of a roll you have: tight roll, open roll, reverse or thing. And this is the step which I'll show you correctly. Shift to one side. I'm shifting to one side, then flatten this and support with an instrument and then tap it to open the graft here. So you can see beautifully it has opened this now, and I'm seeing the S mark correctly. So S is very important aspect for seeing it's correctly placed or not. OCT also gives a nice help in this area. You can see the entire roll has opened. This was a 52-year-old donor. They opened very effectively. Older the donor, the opening of a sheet is very comfortably here. Now we're going to inject air bubble. Once you have a centration now, we can inject the air bubble. So the difference between DSEC and DMEC is, the DSEC surgery has to be under the air. You have to inject the air, then center the graft. Here, air has to be injected towards the end. So entire roll has to be opened onto the surface of the iris. It is like, placing onto the carpet, then opening it. So I'm going to inject the air bubble, and this will push the donor roll towards the endothelium, towards the stromal bed, and complete the surgery. So you should be very, very gentle. First inject small bubble so the graft doesn't get shifted, then increase the bubble subsequently. And keep the bubble pressure for 2 to 3 minutes. You can see the bubble has increased now. 2 to 3 minutes, the surgery ends after some time. You can see OCT very beautifully attached donor lenticule here. So this is the surgery which is absolutely sutureless, like they do a 27 gauge vitrectomy. It is like that for a cornea surgery, sutureless, and the patient is next day can be mobile. This patient had 6-line vision day 1 subsequently. Okay, thank you. I just want to show this only because cataract surgery will be shown by Gaurav.
So I think we'll leave the discussions for the cornea surgeons because I can't lead this, and we have several cornea surgeons here to,
But I learned a lot. Thanks for the Gaurav's meeting on, so that I learned something on cataract and cornea.
So we are working on that to have some sort of all these cannulas which we use for a DALC and for a dissection things, if they can be of material which can allow the transmission of OCT. So we are working on that. Within a 1 or 2 years, we'll have instrumentation like that for corneal surgeries, so that we can see during the dissection also. I think yesterday we saw on the DALC procedure. Because when you are injecting the air through the cannula, cannula blocks the deeper layer. So we are not sure where exactly cannula is placed. So we have to withdraw the cannula, then see where we have made a track. Subsequently, now we have instrumentation which will allow the OCT to go through, and you can nicely see the depth also. And disposable, all of them will be disposable. They are coming with a different material.
Transparent material.
Yeah.
Very good. Good, sir. Wonderful.
I'll try try to show this challenging case which I did recently. This was, I don't know if the 3D effect is there. It's there? Okay. With the right side on or the upside down? Upside down? Okay. Okay. So, this was a patient who was, he had been coming to me for 2-3 months, and he had good amount of phacodonesis. There was a big chunk of vitreous which was coming up from the side and coming anteriorly, touching the cornea. He had a subluxated lens in one eye. The fellow eye, when we sent him for a retina exam, in both eyes he had retinal breaks, and in the fellow eye he actually had a subtotal RD. Which was, initially attempted to be, and he had a brown cataract in both eyes, so, we didn't know what to tackle first. But our retina surgeons, they tried to do a laser barrage and contain the RD because it was a localized detachment, and they were frankly able to control it. And this gentleman is a very senior lawyer in the city, and I was very concerned whether I should actually operate him or not for this eye, because even in this eye, the prognosis was, fairly guarded. So went ahead. I did a femto-assisted surgery here. Let me just show you, once I've done the femto already, then how it came out, and maybe you'll be able to appreciate the vitreous on the side. Now the vitreous was superiorly where, in the area where I was planning to actually sit and operate. I like to sit superiorly to operate. We did a vitrectomy, and after the vitrectomy, anti-vitrectomy and a triamcinolone. Okay, sorry. Yeah. Should be better now. So this is a triamcinolone assisted vitrectomy, and once I clear the vitreous from there, this is then after under viscoat. I go and try to, the advantage with femto is that you can have these cracks. It was a hard brown cataract, and to minimize the manipulations inside the eye, it's always good if you have these cracks are already there. The rexis, you can make a slightly bigger one than what you would make otherwise. And in a cataract lens which is fairly shaky and mobile, doing a rexis manually is definitely going to be a challenge. So the advantage of a 5.2 millimeter rexis made by the femtosecond laser. So here I'm distending the bag again because I'm going to try and put in a CTR, because at this point I realized that the bag was beginning to collapse. So appropriate time. I try to delay the CTR till I can, because it becomes challenging to get the cortex out sometimes. So as early as you need it and as late as you can is the dictum for the CTR placement. And I hope the 3D effect is coming on. Okay. So once the CTR goes in, I do a bimanual insertion and just release it there, and now it's much easier for me to play with the remaining chunks of nucleus. I can rotate them more easily, and there was a superior subluxation, so vitreous was coming back. I went and did another vitrectomy and cleared up some of the remaining vitreous. You can go back in, and whenever you notice any vitreous coming in, you can actually go and remove it in between, because otherwise it complicates the surgery. Now the challenge of getting the cortex, some of that cortex which was trapped behind the, so you have to kind of do it tangentially. You have to, if you pull it in, it will just cause the CTR to come in and the cortex will not come out. So you have to tangentially keep, removing these chunks to one side or the other and tease them out, and try not to hold a big chunk at one go. Hold smaller chunks, and because if you have a big chunk, it will make it, more difficult to kind of remove it. And then, using bimanual skills and everything, you can, it obviously looks much faster. I spent a good 5 minutes getting all that cortex out. I could place the lens in the bag. And finally I could complete the surgery. The good thing is this gentleman came to me on his 15th day follow-up recently, and he is doing 6/6 unaided, and I was very happy because I was very reluctant to actually operate him in the first place, but we eventually somehow managed to get through with this case nicely. So I'll show one more case here. So I think this is another one which I wanted to show. This is a phakic lens. Again, I'll move this to one side. So loading the lens, now this is obviously the most important part of the surgery for me. Getting the lens right in, because if it's not loaded correctly, then it will not inject correctly, it won't open up, it will probably sometimes you'll have an aborted injection or it will twist during injection. So here I'm showing you how to place the ICL and then load it there. And then I make 2 side port incisions. So the indications for phakic lens have gone up tremendously over the years. When I started doing phakic lenses almost 15 years back, we would only do an occasional ICL, 1 or 2 in a month. And now, we end up doing for many of these suspect corneas, especially now even with small parts, especially once Centraflow came out, we now use much more of these with the central hole because the incidence of all the complications has almost gone away completely now. Very rarely that you'll get a complication. So I'm doing a hydro implantation here, as you can probably see. I don't use viscoelastic for this either. I like to inject my IOLs and the ICLs under infusion. So in my left hand is infusion, and in my right hand now I started doing this because 7-8 years back we had with sodium hyaluronate we had some TAS in a few patients, and ever since I decided that I'll only use viscoelastic at the time of rhexis, and after that I don't use it unless it's absolutely necessary. Here also, you don't get IOP spikes, you don't get post-op inflammation, the vault remains more stable post-op. In many ways this is good, but frankly for your first 100 cases of ICL you should probably still do them under viscoelastic. Once you are very comfortable with the injection technique and manipulations under infusion, only then can you go and start doing under infusion, because the scope for error is very small, and these eyes are more delicate, they are having deep chambers, iris can come out very easily, so all these manipulations can be done. So the good thing is that the moment you have completed this, you can then check the intraoperative OCT for the vault. Now this used to be a big issue for us, because post-op you would get surprises, you can't assess the vault on table otherwise, and we used to struggle because you would sometimes get a very low vault for maybe 100 microns, and sometimes you'll get a 1 millimeter vault, which can be a big surprise. So nowadays we like to check this on the OCT, and I'll just see if on this particular case we had OCT towards the end. That window might pop up on the right side at the bottom, yes. So here we normally check whether the ICL vault is good, and here you can faintly make out because of the artifacts over there, but I usually have better videos than this for the vault, but somehow today's video is not showing the vault so well. All the same, it's very good to see it, and if you do have a surprise, I think this might be very useful for those surgeons who do both eyes on the same day. I don't do both eyes on the same day at all because I don't like to do it. I learn from the first eye and make it better for the second eye. But if you do get both eyes on the same day, you can check the vault on table and take decisions about whether you want to resize the second eye or do something else differently. And I'll just show one quick other video which I thought might be relevant today. So this one is in 2D. Can we temporarily switch? Or wait a minute, don't switch it. I'll just take you to, because this is basically standard femtosecond laser, so we'll just bypass it and take you. The thing was that this patient was a posterior lenticonus, and I'll just take you to the place where, so if you notice here, and I don't know whether you can see it, the laser was detecting the posterior surface of the lens incorrectly because of the lenticonus. This was a young man who had, so we had to correct that, and once we fired the laser everything looked good. So I'll take you here now where the 3D video starts. So frankly, this young man, he came to us with progressively worsening vision, and he could not accept glasses, he could not accept contact lenses. He was about 6'18", high astigmatism, so no obvious cataract at all. We started looking at him, we did an OCT and we did eye trace and everything. We found that corneal aberrations were almost negligible, whereas the lenticular aberrations were very high. On slit lamp photographs and on OCT it showed up as a posterior lenticonus. We decided to go with surgery. The patient was very insistent that he wants, he's a young man, he's about 25. He wanted best possible vision. And this is a time when we were just starting Synergy Toric about 3-4 months back, and Toric was not yet available, so we delayed his surgery by almost a month, getting a Toric Synergy, because he had some small astigmatism. It turned out well, so essentially we were able to go ahead with the femto-assisted surgery. Now, what I wanted to show was that the posterior capsule may not be picked up correctly in the catalyst on the laser, because the OCT scan is used to a particular shape for the posterior lens. So you have to be very careful. If it doesn't pick it up correctly, you may fire through the posterior capsule. So you can't skip through those steps like without looking at them very carefully. Occasional patients of the OCT will not pick up the posterior capsule of the cataract so well. Now anyway, here we were able to now proceed, because I like to do my premium IOLs, especially if I'm using multifocal torics. I try to use them with the femto laser, because all the steps become much more predictable and accurate as a placement of the capsulorhexis, and if I have to do some LRIs or if I have to put my toric marks, everything comes out really well. And this patient eventually had So the best part is we can operate on almost very low light. It's so low, but you can see it very clearly on the screen anyway. And the patients are very comfortable, especially those who are photophobic or under topical anesthesia. Sometimes, patients are, not, they don't take kindly to very bright light. And even the Callisto system, which is basically used for the markerless surgery, here I'm using the Callisto to align my lens, works on very low light. I've been using Virion for almost 8-10 years now. It requires you to have much brighter light, whereas on the Callisto now we realize that we can work on very low lights, and you can see that I'm aligning it correctly on the axis with the Callisto, and then finishing off the surgery. Can you switch it for 2D for a moment? For this patient only, I'll just show you how his post-op eye trace looked. I think I have that here. Can you switch it to 2D for a moment, please?
I think both you and Dr. Titial brought out the important thing using 3D is using low illumination, and it's very good for macula, because any UV light is not good for macula. That's why ARMD happens, and maybe one of the reasons for visual acuity not improving after a good surgery is maybe macula is damaged. We don't know how to study the functional loss due to light. So I think one more thing I do with Constellation is they keep the pressure at 20 only, and I don't increase more than 20 because optic now can be compromised. And then this illumination, and you can use the 5% light and still.
Also here I think Dr. Titial sir, all of us are now operating on very low IOPs. I am operating on the Signature, I am operating at just about 30 millimeters of IOP, and on the Centurion also about 35 to 40.
Because if you have the light more, and then the light is getting focused on macula for longer, and with the low light, I think macula will be protected. Many times I remember we used to put a cotton bud to keep the light away from the, particularly during.
So this was the slit lamp picture. Patient presented with diminution of vision. On the eye trace, you can see that the DLI was so bad. It's just 0.81. So dysfunctional lens index. Usually it has to be around 10 in a healthy young patient, and it can go low as the cataract progresses. Typically, if it falls below 5, that's when you start thinking that lenticular aberrations are very high. Samresh has a very nice talk on this. So here, if you'll notice, these are the internal aberrations. So these are all from the lens. And these are the corneal aberrations, which are negligible. So you'll see that the corneal aberrations are very small. Lenticular aberrations are very high. And if you compare both eyes, this patient obviously has lots of visual complaints with starburst and halos and everything. Patient was very unhappy, and frankly, if you look at the E test here, this is how his E looks, and this is how his E looks in the left eye. So obviously we needed to do something. This is the posterior lenticonus on OCT that we picked up on both eyes, and went ahead with that surgery. I won't show you the video. And we went with both eyes at a gap of few days with a synergy toric. And post-op day 1, obviously patient was 6'9", and then he settled down. So I wanted to show you this, that post-op with the toric, we had almost a perfect correction. This is the eye trace, which shows you whether the toric check, what it is showing. It shows that my eye, this is the placement of the, this is the corneal astigmatism, and this is placement of the lens. They are absolutely spot on, and it shows that, if I rotate my lens by 2 degrees, I may get a 0.01 change, which means that it's almost perfect toric placement. So both eyes did extremely well, and by day 15, patient was 6'6" and N6 unaided. So I'll just stop here, and I'll invite our next speaker if there are any questions.
I had a question. Very good videos. So did you rule out, I'm not sure if I've seen this patient, but so we've reported with lenticonus, Alport syndrome is a very important thing which has to be ruled out. And we've reported this in BMJ case reports that in the retina on OCT you can find temporal thinning, symmetrical, bilateral. Very recently we reported a couple of years back. So I'm not sure if the posterior segment OCT was done, because that is, and nephro issues are very important in these cases of lenticonus.
So since he went for a synergy, he would have definitely done OCT of the macula and checked for.
The changes are subtle. So they'll be just thinning temporally, and nothing major, and it can be missed. And systemic evaluation is very important for the patients to rule out nephro issues.
I remember we had another patient sometime back where we had all these problems.
Yes, we've reported that.
Yes, sir. Welcome, sir.
Dr. Titial sir is here. Good morning, sir. Dr. Natarajan is here. This is basically vis-a-vis 3D surgery and 2D surgery. Like VR surgery, we know that it's like something. Till I knew that light illumination is low, and that's good. For cataract and corneal surgeries, like how do you find is better than what is the difference? We operate on 3D when we operate in routine.
So, sir, the thing is that what I've understood over the last few months that I've been using it, and Dr. Tityal is using it much more than me. But the experience is, first thing is you are not restricted by seeing into the microscope. You have a very big monitor which is just 6 feet away from you, and it's a 4K monitor, and it has enhanced illumination. So what happens is that you know on the microscope we keep trying to increase our light to be able to see better, but on the Artivo system you can just have very low illumination. The system itself augments the lighting so well that you are seeing it in a very good illumination, even though your microscope illumination is very small. The resolution is amazing, and as Dr. Tityal mentioned before in the day, you can magnify, you can zoom in to almost to a field where you can probably see a small laser PI in the iris only on the big screen. And even if you zoom into the fullest magnification, you don't lose, there's no distortion, it's absolutely clear. So what I've realized is that sometimes if I'm going to the PC and trying to pick a spec from the PC, I will be able to zoom in without any distortions, and the focusing is amazing, because what happens is when you start the surgery, you're supposed to go to a very high magnification, focus on maybe on the iris plane or something. Then the system picks up the depth of focus for all the depths. After that, if you bring it to low mag, it will maintain the depth of focus and it will remain focused on all. So frankly, the depth of focus is also much more than a conventional microscope. So it's several things put together, I think, the illumination, and then of course, neck fatigue, and you're just wearing those glasses. So here, frankly, the 3D effect is maybe only 10% of what we actually see in the OT. Dr. Tityal sir, would you agree? I mean, what we see on the screens and what we see in the surgery is probably 10 times better than what we are seeing here for some reason. Yet, it is still something which we have to get used to.
Absolutely true, Gaurav. Screen visibility is fantastically better. And I'm not sure about a BR surgeon, but for cornea surgeon, it's 100% requirement for us. Now, nobody in our center, cornea surgeon, operates without the OCT attachment. And OCT is the boot. You may not have 3D device, but OCT is must for a cornea surgeon. In fact, all surgery nowadays. Cataract you may not require, but cornea and retina surgery, it has become a compulsory tool. And this headset device will increase the perception, what Gaurav told us, magnification, the contrast, and the field also is comfortable for you. You can see the entire field, and OCT also in front of you. While if you don't have a headset device, your OCT is in your microscopic field, and that disrupts your visibility, which we did for 3-4 years till we acquired the the headset device. Now OCT you can see beautifully. You can shift the microscope if OCT is coming towards your view. You can shift the tilt also. The OCT will shift to one corner. So everything can be done, and you can see much better in that. So I would suggest people should, if possible, acquire these new gadgets.
Thank you, sir.
Even personally has come with 3D.
Yes,
I heard a quality is a problem, but somewhere where they cannot afford, I think probably look better. People using are telling they're okay. I have not tried it, but good. I think.
So now we have Dr. Samresh, who's from Jaipur, and he's no stranger to all the top speaker podiums. He has actually developed his own 3D system, and that's the unique thing. This is not on the Artivo or on the Ingenuity. He has his own 3D system set up, and he will also later in the day be sharing how he has improvised his recording systems to give 3D views. So please, Dr. Samresh, go ahead. He's a whiz with all the gadget and technology, so I'm interested in seeing what
Thanks a lot, Dr. Gaurav.
Oh, one more thing I want to say, Dr. Abhaya sir told me I should visit the new hospital which he has made. I told him we are proud of you.
I was lucky to visit, and it's like an art gallery.
Exactly. So that's what.
It's amazing. The way
can you
he
show
does
some
it.
pictures after this?
Each place and each room is so artistically done that you enjoy. I'm sure patients love going to his hospital as well.
Thanks a lot, sir. Thanks a lot for that kind introduction. And before I start, I'd like to thank Team Drishti Institute, Dr. Gaurav and Dr. Saurav Luthra for inviting both me and Vaishali. And it's been lovely so far, and thanks for taking so much care. So I'm going to show you on surgery, a cataract surgery that went wrong. This was recorded probably a decade ago using a homegrown 3D setup, so the resolution may not be as great. And also I think you'll have to wear the glasses straight, because when we tested, we flipped the video, so you don't have to reverse your glasses. I would say straight should do. So getting along, can you appreciate stereopsis?
All right. So it's going to get a little better as things pass on. So this is one of our fellows who's doing a cataract surgery, and this is the first chop maneuver that's been done. You can make out that the fellow's a little scared up, because the it is under observation and trying to rotate the nucleus, but finding it a little difficult to go ahead with it. When you're doing a rotation and you find that the nucleus rotation is difficult, I think it's always a good idea for any cataract surgeon to go back and re-inject, do a repeat hydro, and try to clear up that area of adhesions before you try and do a forceful rotation. Nonetheless, rotation happened in this eye, and again you can see the visible shakes of the novice surgeon trying to do the second chop maneuver, and notice how there was a sudden deepening of the chamber over there. On the whole, everything looks relatively okay so far, except for the fact that the chamber is deepened, and you can see some part of the lens edge being visible over there. This is the second chop that happens. Again, the parameters are very well controlled, so it's not really a very high bottle height or a very high vacuum or very high energy. Everything is under moderate control because it's under observation. The surgeon is under observation, but notice that there is an area of clearing that happens over there. Somewhere in that corner over there, an area of clearing happens. So something is clearly amiss, and especially when a nucleus that has been freed and you've seen a wave class but finds it difficult to rotate, one has to suspect something going wrong early on. I'm just going to move ahead in the interest of time to show you that once the nucleus has been removed, there was a big area of clearing that you can see at the distal end. When you have a clearing, it knows, all the cataract surgeons know that sinking feeling that the posterior capsule has been breached. When something like this happens, always to aid is triamcinolone alone, which stains the vitreous and shows you, and you can see how clearly, I just pause here to show you very clearly how vitreous was so clearly visible, and sometimes it's not visible with the naked eye, and you can go ahead with surgery and the vitreous tends to get churned with the nucleus and the surgery becomes a bit of a mess. Once you find out that there is vitreous inside the eye, you are committed to doing a vitrectomy before you go ahead with the cataract surgery. So notice over here, this 3/4 of the nucleus is still in the eye in the capsular bag, and there is vitreous prolapse right in the area of interest where we do our phaco, which is the nasal edge of the patient, because this is a temporal surgery. So before doing a vitrectomy, before doing a cataract surgery, we decided to do a bimanual vitrectomy, and in our hands at Raghuti, what works best is a bimanual pars plana, where the limbal irrigation on the left hand and a pars plana vitrector going behind the posterior capsule through a trocar cannula system tries to eat up the vitreous behind the posterior capsule. The idea is that the anterior chamber is maintained and the compartmentalization, the anterior chamber is pressurized using an irrigation in the limbal, but the pars plana will eat off vitreous in its physiological compartment, which is the posterior compartment of the eye. So rather than doing an upward drag movement by putting a limbal vitrectomy and trying to prolapse that whole vitreous anteriorly, we approach the vitreous from behind, which is from the pars plana route. It sounds very difficult, but it's not, because all you need to do is to get the right marking. You want to get at a 3.54 millimeter entry behind, and you want to use the vitrector with the highest possible cut rate as a cataract surgeon, with a low IOP because you don't want to overinflate the chamber, and a moderate vacuum that can pull the vitreous. The other advantage of using a vitrectomy in the pars plana way is that you can not only do vitrectomy in the area of the posterior capsule rupture, but you can go beyond it. You can go beyond the edges and clear off a little more vitreous than just the area of the PCR, because you don't want this vitreous prolapsing anteriorly when you plan to remove this nucleus. Otherwise, again, the vitreous will come into the phaco probe and you will cause a traction. So once I've cleared enough, there's a small area of nucleus and a little bit of vitreous which is hanging anteriorly, which I'm just clearing off with a vitrector. I'm also doing a vitrectomy in the area of the PCR anteriorly, just to make sure there is any loose strand which has not been cleared pars plana can be removed using the limbal route. But now that I'm sure that there is no vitreous in the anterior chamber, I go ahead with the phaco. But the interesting thing to note over here is my irrigation and my phaco are now split. So the left hand has irrigation because I don't want the irrigation currents to go directly in the area of the PCR, but the right hand has the phaco probe which has the aspiration and the phaco energy, but interestingly no irrigation. So it's a bimanual phaco system. This helps me, and it will help the surgeon in keeping the irrigation fluidics to your advantage, keeping them away, not directed in the area of the PCR. And notice that because there is no vitreous inside the eye in the anterior compartment, because it's all been taken care of at the posterior route, your phaco goes on just as planned. You really don't have to worry about nuclear fragments getting entangled or going posterior, because your irrigation is not pushing your fragments posterior, and the phaco energy is being delivered right in the center of the eye where it is expected to be delivered. It's not 100% proof, but some fragments may go down because there is obviously fluidics inside the eye, but on the whole it makes the system more controlled. When it comes to cortical and epinucleus removal, bimanual tends to work best because it's a closed chamber and main incisions can leak, so my preference over a coaxial would be a bimanual IA. Again, because there's no vitreous, you can go ahead with your parameters. So notice how we have a flow rate which is on the lower end, because we don't want to have things fast, so we have a flow rate of 6, which is a very low flow rate, because we want a lot of control. And especially in the area of PCR, we want to hold and slowly pull these cortical strands centrally, so that we do not cause any tractional damage or enlargement of the PCR, which was the damage that had to be done was already done. But we try to make it as less worse as possible. So this is using using aspiration in one hand and irrigation in the right hand. But when you have to even do an exchange of instrumentation, it's always good to inject a dispersive viscoelastic before removing these instruments if you want to do an exchange of hands. But for now I'm trying to do as much as possible with the first incision only. Notice that area of the PCR over there. I'll just show you the area of the PCR. You can see there's a full split posteriorly, and because there's no capsular bag integrity, our choice of lens shifted from a monofocal hydrophobic single piece lens to a 3-piece lens. Because the anterior capsule is completely intact but the posterior capsule is given way, bag fixation is not possible. So we decided to implant a 3-piece lens inside the sulcus. Sulcus is stable, but the important thing to understand is that 3-piece lenses are the lenses suitable for sulcus implantation and not the single-piece hydrophobic lenses, because those thick haptics in the long term can cause complications including chronic uveitis, macular edemas, and God knows what not. So it's always better if you don't have it. If you don't have a 3-piece, it's good to have an inventory, but if you don't have it, just let it pass and do not put a single-piece lens. But what's more important is that to stabilize a 3-piece lens inside the eye, what we are doing over here is an optic capture. So the haptics are inside the sulcus, lying on the sulcus, but the optic is being pushed behind the anterior capsular excess margin, first temporally and then nasally, so as to cause a locking of the lens. And once the surgery is over, the lens is locked into place and vitreous is checked for, and that's a stable lens which will unlikely to be moving later on in life as well. Thank you. I hope it was visible in 3D.
Came out beautifully, Samresh. We could actually see your the best part was when you were doing the vitrectomy from the pars plana. The cutter was visible, and that the PCR became visible so nicely with a good depth perception. So I think very good teaching tool as well when you have such complex cases that you are operating. And I'll agree that the physiological area where you're doing the vitrectomy, you're not allowing it to come forward or drawing it forward and then cutting it, because then it just keeps coming. Whereas if you just go there and clean it up, you'll probably just clean up that area and you're not disturbing the rest of the vitreous and allowing this thing. So I really appreciate that. I'm sure all anti-segment surgeons should know how to use a trocar and be able to do a vitrectomy. And I'll ask for any comments from others.
What is the innovation you have done? Because you made it homemade, you said, no? Oh, okay.
Good afternoon, everybody. So Tushar is again a brilliant young guy. He is very dynamic. He has quickly made a great reputation for having some of the most amazing videos. He's actually innovated some new techniques and published them, and some of his videos are have a few million hits on AJO and other places where they've developed Dr. Rohit, and both of them are doing amazing work. So we are lucky to have Tushar for our videos here.
Thank you so much, sir. First of all, I would like to thank Dr. Gaurav and Dr. Saurav, sir, for giving me this opportunity. So today I'll be, can we have the lights off and 3D on? So today I'll be giving 2 talks. My first would be, this is a patient, a 70-year-old patient with a wide intumescent cataract. So I'm going to show you how I'm using intraoperative OCT and 3D to my advantage. So I start the case by giving a calibrated main port incision. So this is a calibrated main port incision to make sure there's no leakage. You can see in the intraoperative OCT with the fluid fill pockets, which we can see here. So I, just to make sure before starting with the rexes, I was sure that there were fluid-filled pockets. So I injected adrenaline to make sure that the pupil is dilated. So the Trypan blue staining technique I'm doing is a modified 30 gauge needle technique, which is an under air Trypan blue staining technique, which we have published also. So there are quite few advantages. It is an under air technique where I'm going to use a 30 gauge needle through the peripheral cornea. So you can see few drops of Trypan blue is used to stain the cornea. Can you put your glasses upside down for better visualization? So this modified Trypan blue staining technique has numerous advantages. There is no egress of fluid, there is minimal spillage of dye, and then there is no shallowing of anterior chamber while you are doing the. So it works best in shallow anterior chamber. So I'm using saline to take out Trypan blue, followed by visco injection to take out the air bubble. So now my plan here is to do a calibrated side port incision as well. So this calibrated side port incision, I make it with a 25 gauge needle to make sure that there is a perfect chamber stability, minimal leakage across the surgery. So now my aim is to so now what I'm going to do is, before starting the rexes, what I'm doing is I'm using a 30 gauge needle. So I'm taking an advantage of intraoperative OCT using a guided closed chamber 30 gauge needle decompression in the central area of the capsule. So I'm taking the 30 gauge needle and I'm piercing the central part of the capsule, and with the guided intraoperative OCT guided, you can see that I'm aspirating the fluid in the central part. So what is happening is I'm trying to decompress the area in the central part of the capsule, so that I have a decompressed area which is confirmed with the intraoperative OCT. You can see in the right side there is a decompressed area in the central part with an increased interventricular pressure in the paracentral area. So this was the aim. So now what I'm going to do is I'm going to make a small rexes in the area, only in the central part of the area. So I'm injecting viscodispersive, which ultimately reduces the interventricular pressure. A viscocohesive is a better thing to use. So now I'm making a small rexes in the center, which has a decompressed area in the center. So you make a small rexes in the central part. And now, as I showed you before in the intraoperative OCT, you can see that there is a increased pressure in the mid-periphery area. So what I do is I use capsule milking technique, beautifully described by Dr. Chi Soon Fei, where massaging over the capsule from the periphery to center so that the fluid comes out from the center. And simultaneously what you can do is, after that, aspirating the fluid so that it ultimately debulks the bag. So I'm debulking it by aspirating it. So with the help of intraoperative OCT also, we can, I will show you. So again, what I'm doing is I'm taking out the rest of the fluid from the mid-periphery by aspirating, and often by capsule milking. You can see that the fluid is coming out, the remaining fluid. And I'm seeing the intraoperative OCT also and doing a aspiration, guided aspiration. You can see here now in the OCT that it is all debulked. So now I'm taking, with the vanas, I'm making a nick, and now I'm trying to make a rexus. So now the capsule behaves just like a normal capsule. So you don't have to worry, because you have already debulked it, and you can complete the rexus beautifully. So you can see that I'm completing the rexus, and the capsule behaves just like a normal capsule. So in these cases, because white cataracts are often hard, so I use a supraphysiological IOP of around 40 and an aspiration rate of 42, 46, and I'm doing a direct chop here, and it becomes a routine case. So I've chopped it into multiple pieces, and you can see it can come out. The epinuclear sheet is also out, so there was hardly any cortical material left, and did the cortical aspiration with IA and followed by IOL implantation. So sealing of the incision is also confirmed with intraoperative OCT in this case. So coming to my another case. So this is a case of posterior polar cataract with a pre-existing defect, and we do preoperative OCTs in all the posterior polar cataracts. The paper is beautifully published by Dr. Tityal. You can see here, as he has already mentioned in his paper, this is a moth-eaten appearance which shows a pre-existing defect. So this is the posterior polar cataract with the pre-existing defect. So calibrated incision, main port incision, which is not to be made parallel to the pre-existing defect, because if you make it parallel, then it gives overstress to the posterior capsule. Not to overinflate the bag with the viscodisperser, that's another point. Calibrated side port incision with the 25 gauge needle to give a good chamber stability with minimal leakage across the procedure. So my preferred rhexis is an oval shaped rhexis in all posterior polar cataracts, because you can take the advantages of both the small arm and a long arm axis. It is being beautifully published by Dr. Kiran in JCRS. So the small arm of rhexis, it gives an advantage of an easy IOL optic capture later on. It gives you a good nucleus piece retention in the bag, helps in tamponading of the vitreous, whereas the large arm of rhexis helps in no rise of intracapsular pressure, safe end-to-end sculpting. There is easy division, easy sub-incisional cortex removal, and a smooth IOL implantation. So after making the oval rhexis, so my parameters specifically in this case with a pre-existing defect would be, I would be using a physiological IOP setting with an IOP of 20 millimeter and an aspiration flow rate of 23 to 26 millimeter. So my aim of using this parameter is that, so that during the procedure there is no posterior bulging, there are no pressure differences between the anterior and posterior segment. So when you have no anterior posterior segment pressure differences, you can see the nucleus is floating freely in the anterior chamber, and the low infusion of the fluid helps in preventing hydrating of the vitreous. So I'm going to use the low IOP phacoemulsification to prevent any further stress. My plan here is to do stop and chop technique. So I start with the sculpting. I realize that it is very soft, overly soft. So I instead tried doing a cross chop, but it was not happening because it was an ultra soft cataract. So what I did here is I shifted to phacoaspiration and gentle mechanical separation of the nuclear and epinuclear plates. So you can see with the help of I'm doing phacoaspiration, and with the help of chopper, blunt chopper, I'm just mechanically separating the nuclear and epinuclear layers. So before taking out the chopper, always remember to inflate the bag with an OVT to have a good chamber stability. So now what I'll do is I'll do a visco separation, gentle visco separation, being done with the cannula, visco dissection, and I'll be using a J-shaped cannula for doing a visco dissection sub-incisionally, so that it is free from all the ends. It has to be done very gently. There should be no undue deepening of the chamber to prevent any stress on the posterior capsular defect. So I kept continuing phacoemulsification as I was sure that the hyaloid phase was intact, as the patient was a younger age group, and then there was no peaking of the pupil, there was no vitreous in the ACs, and plus with the help of low IIP phacoemulsificant, you can see the nucleus is just floating in the AC because of the minimal pressure differences in the anterior and posterior segment. So I'll be using the dry aspiration technique described by Dr. Gills long time back. So what I'm doing here is I'm doing a very slow irrigation, aspiration, then teasing of the cortical lamellae and stripping them. So dry aspiration works beautifully in these cases with preventing any hydration of the vitreous, doing it from the side port so that it should not collapse the anterior chamber. So that is also very important. And with the visco expression, slow visco expression, the cortical matter is taken out. Triamcinolone acetate, just to make sure that there is no vitreous in the AC, and then a 3-piece IOL into the sulcus, as beautifully shown by Dr. Sambresh in his previous video. This works best in such cases. And followed by an optic capture, as I'm taking the advantage of the oval rexus, the small arm of the rexus. So now it is optic captured. And then again, final checking if the vitreous is still there. And the case is completed. Thank you.
Dr. Tityal sir, any comments on this?
Wonderfully demonstrated, both the cases, because these are the challenging situation for any surgeon. And imaging has changed the concept of manipulating your thought on the table, because sometimes we see the patient and we have a certain plan in the mind, and those plans may not work out on the table as such. And if you can see things inside the table with these OCT attachments, you can modify your surgical pattern. I'll be showing some videos of mine also subsequently. Idea to show these type of surgeries, not to showcase our expertise in that. Idea is to inculcate some sort of a thought in the people sitting in the audience, to have good examination of their case, picturize what OCT picture would be in their slit lamp imaging, and if you have access to anti-segment OCT, you can have the same pictures in anti-segment OCT also, and you plan your surgery accordingly. So these surgery which we are showing is actually giving you some sort of thought, like this is a case which might behave like this on the table, what should I do for those cases? And beautifully shown to Shreya, and it was really good.
Thank you, sir. And we, sir and us, we have been conducting instruction courses in American Academy every year. This year also we are conducting white and posterior photo. Thank you.
It's very essential, as he has pointed out, that in a case of intumescent cataract, the peripheral decompression is essential, because recently what happened was, there was a case of intumescent cataract done by femto. The rexus was fine. The capsule came out, the rexus part. And the moment I injected the fluid, there was a tear, right in the 3 o'clock and 9 o'clock position. So, as you pointed out very rightly, that you compress it from the sides, take out the lens matter which is present, the fluid present in the periphery of the nucleus. Only then such things will not happen.
Thank you, sir. Thank you.
Shusha, what's the visco you were using for visco expression?
So basically, I was using a visco-dispersive, but as I mentioned, visco-cohesive is a preferred one. Yes, sir. Yeah, dispersive will be better. Cohesive only to equalize the interlenticular pressure.
For visco dissection and visco expression, I think cohesive will be better.
Yes. So for visco dissection, visco-dispersive is the preferred one. Thank you, sir.
Yeah, for Tityal sir and for Luthra sir, and for those who use the 3D very regularly, I just have 2 points. One is for people who do wear a distance correction. Is it when you're doing like, let's say, 2-3 cases in a row, do these glasses tend to slip on and off? Real world problem.
That's a good observation, you know. And for that, you know, because we have two glasses, one of mine and the other has to be that Polaroid glasses. So, because luckily we put nowadays, I put a, you know, adhesive in my mask, and that holds my, you know, these spectacles. And every alternate week I have to tighten my, you know, glasses so that it remains fixed. And I normally operate, you know, 3 to 4 hours continuously because I have to do around 50 cases. So by the end of 50 cases, my head is paining because there is so much of compression happening.
Right.
So that is one thing, but sometimes it keeps coming down. What I do when I change my gloves, the paper I don't throw. I make a paper folds and that becomes strong. So I just do like this and settles my glasses. So that's without anybody's help. But yes, if you are doing a few cases, it doesn't compress onto your temples. And even my glasses are very, very tight because it should not come down. Otherwise, then you are seeing like this and gives a very difficult view. Nice observation.
And the other thing that I think I'm sure the RTO and all companies which will come up is the lack of the surgical parameters, both for retinal surgeons and cataract surgeons, particularly with all these lovely cases that we saw.
We are working on that because what is happening from RTO, it is a 4K recording. And for Callisto, it is the HD recording. And the Alcon machine has the HD cable. So all three are not matching. So we require another device which can take all these three to get a recording where we can have those panel also coming. But that is costing almost 20 lakh rupees than each one. So we are working on that.
I think it's just the industry who don't want to cooperate with each other.
That's your absolute
And all three people have to get together to get that thing done.
I've been trying for 6 months to get this to work. I'm still not succeeded because the Zeiss person blames the Alcon person. The Alcon person blames the Zeiss person. He said they are not able to give me a feed. But so the thing is, what sir is saying is right. To get it to the 4K monitor is going to be a little more time consuming.
We have done Gaurav, to do your live surgical transmission. We have that attachment. We borrow that for that particular session.
Right.
But to buy that is going to cost 20 lakh rupees for each device.
But sir, what I understood is that from the Centurion, you can, because it has an HD image overlay, it will go to the 2D recording of the Lumera, on the RTO system. So if you're showing a 2D recording, you will still get it. But on the 3D monitor, it doesn't come.
In that, you will not have a OCT coming.
Then you don't have OCT. Absolutely. So there are lots of ifs and buts. But all good questions. And the glasses, they have many kinds now. You also have a visor. So you don't have to put on the glasses, but even the glasses are quite comfortable. I wear over this. I don't have any issues. They have 2-3 kinds, and there are also like safety goggles kinds, and there's a visor, and so there are many kinds. But frankly, when you sell a machine which is at this cost, you should give all the options rather than just say, okay, we have only this and anything else you want, you buy it yourself. So they should be giving us all the 3 options, but all the same. So I think with that we come to an end to this first very interesting session, and we are going to start Dr. Tityal's rotation next. But before that, I would like to request Dr. Tityal sir to please give away a few mementos to our panelists from the first session. So I'll request sir to please give a small token to Dr. Harsh Bahadur sir, Dr. Vinod Arora sir, Dr. Rizvi sir I'm not seeing right now. Dr. Smita Mehra, please. Dr. Amit Singh. Dr. Sushil Ojha and Dr. Neelam. Even though we couldn't pull you to the dais because of the 3D screen, but now we are on to the LED, so I think we'll now be able to have everybody sitting in the right place. Thank you, sir. So with that, I think we move on to the next session. And I would like to invite the chairpersons for the next session, which is the oration session. I'll request Dr. Dinesh Sharma sir to please come, Dr. Rajesh Tiwari. You can come to the dais now. I mean, please come, sir. Dr. Sanjeev Mittal and Dr. Anand Vardhan. And I'll request them to take over the proceedings from here.
इसको मैं बंद कर दूँ क्या रहने दूँ इसे So we start with the most important part of the session, the oration part. I will start with a share. फैले हैं रंग देखिए हर एक समत, समत मीन दिशा, मसाफे जिसको वो खूबसूरत पल है आज, means struggle of life that leads to achievement and success, and that is the moment for today for the Drishti Eye people. I would like to congratulate the Luthra family and the entire staff of Drishti Eye Institute on their 25th anniversary. We must also know the man behind the inception and growth of this institution. Dr. M.C. Luthra Sahab was totally dedicated to the profession, soft-spoken and a humble personality. Born in Allahabad, got his medical education, both graduation and post-graduation from SN Medical College, Agra, and after completing his post-graduation in ophthalmology, he moved to his Karm Bhumi, Dehradun in 1968 and started his career in ONGC, from where he took voluntary retirement in 1996 as the chief eye surgeon. His accomplishments were not limited to his profession. People who know Luthra would remember that he was very active academically. He used to participate as well as organize numerous conferences. He was one of the founding members of the Dehradun and Uttaranchal State Ophthalmic Societies. He believed in giving back to his roots and organized almost 200 eye camps under the banner of IMA, Rotary Club, ONGC, and other organizations. He also established the IMA Oxygen Bank and the family planning camps to promote the overall health of the community. For his achievements, he was awarded the Lifetime Achievement Awards at the Uttarakhand State Ophthalmic Society Conference in 2008 and North Zone Ophthalmic Society Conference in 2016. Both his sons, Gaurav and Saurabh, with their hard work and dedication, have taken the establishment to new heights. And we hope and pray that the next generation will follow the footsteps of their father and grandfather to make it a world-class facility. Thank you.
Can I have my slides, please? Thank you, sir, for your blessings and for the introduction. And we are really thankful to all the chairpersons of this session for gracing the occasion. Luthra, I won't go into these because Sir has nicely, enumerated that. And the Dr. MC Luthra Gold Medal Award, also in UKSOS, was instituted in his name in 2002, and he was very active in Rotary and IMA. So the past recipients of Dr. MC Luthra oration was Dr. Ekar Grover in 2013, Dr. Mahipal Singh Sajdev in 2014, Dr. Kumar Doctor in 2017, and Professor Amod Gupta in 2018. And we are very proud to present this oration this year to none other than Professor Jeevan S. Tityal, who is a Professor of Ophthalmology and Chief at Dr. R.P. Center for Ophthalmic Sciences at AIIMS. And he has a huge CV with more than 400 publications, more than 7,000 citations, 6 books, and more than 60 chapters, delivered more than 50 orations and keynote addresses, and regularly conducts instruction courses in various international forums like the American Academy, SCRS, European Society of Cataract Surgeons, and so many others. Amongst the top cited researchers in 2021 ranking in ophthalmology in India according to Stanford University, has 2 patents to his credit and has several international awards and honors with the Distinguished Service Award of the APAO, the Senior Achievement Award of the American Academy and Asia Pacific Academy, and the first Indian to perform live surgery in Ascaris, USA. And he was awarded the Padam Shri by the President of India in 2014, the P. Siva Reddy International Award by the AIOC, and the R.P. Dhanda Award by AIOC, 4 gold medals. And he has been the president of the Indian Society of Cornea and Keratorefractive Surgeons and the past president and secretary of DOS. So with these words, I now invite Professor Tityal to please deliver his oration. So we would like to honor him first and then followed by his oration. I would request the chairpersons of this session to please come forward and honor him with the oration.